on site here? Who's here?
So we have 5 on site, and on
Mm-hmm.
Teams we have one person, and Hayden.
Right, okay. So the plan was to have a little chat about diagnosis and management of the of thyroid cancers generally. Um, it's difficult. I'm going to try and do it a little bit interactive with asking some questions, and especially when we go through the paper, we just want you really just to comment on some aspects of the paper if you can. Um, but I'll start at fairly basic, really. So obviously, how do we assess a patient who's got a thyroid nodule first of all when they come to the clinic? Um, let's ask a quick question. So let's start with you, Haytham. You're full center in the screen there. You got a young lady who comes along to the clinic with a nodule in the thyroid. So how are you going to assess her? What's your plan?
If she's a lady and in clinic, we are gonna go through the history first, which should include the age, and the age is important to know if we're talking about thyrotoxicosis or is she a lady with a suspected thyroid nodule. It will
Yeah,
be important in staging as well.
yeah,
Family history, including any cancer in her family, first degrees, or exposure to radiotherapy, which is a part of one of the risks of PTC.
yeah.
Uh, Examining her for sure about in clinic whether we need to know which side is the nodule. Is it going retrosternal? Are we talking about a goiter or suspected cold nodule? And
Yeah.
if we have an ultrasound in clinic, we can simply do it informally or formally. It will help us in staging the U classification for thyroid nodules.
Yeah.
If we can aspirate, even like a thyroid cyst would be good,
Okay.
and hopefully go through the investigations later on. But initially, the history is important in everything, excluding the high risk patients, whether we're talking about a goiter, any thyrotoxic symptoms, is it a
Yeah.
hot nodule, and which investigations are we gonna run through?
So the three main investigations obviously are simple bloods, TFTs. We might do some antibody assessments if we think it's a general thyroiditis picture. We're going to do ultrasound and fine needle aspiration, aren't we, if it needs it. You mentioned the U classification, and can one of the guys in the office tell me a little bit about that? Is anybody in there? Erica?
Yeah, so the U classification. So that will be the ultrasound classification for thyroid lumps. So it will
Yeah.
be U1 to 5. So U1
Good.
is normal.
Yeah.
U2 is small changes, I think.
It's just benign. Yeah. It's a benign
Benign,
feature.
benign.
Yeah.
And then U3 is intermediate.
Indeterminate.
U4 indeterminate.
Yeah.
U4 is maybe malignant, and U5 is malignant.
Yeah. Suspicious of malignancy. U5's highly suspicious of malignancy, really, isn't it? Um, who else is in the room, Erica? Everybody else has gone into sort of off focus. You're the only in sharp focus. I don't know if they're hiding in the background there. But the U classification is a moderately useful tool. Uh, its sensitivity and specificity is nowhere near as good as fine needle aspiration, obviously. That the FNA is the gold standard, really. And so we've had a number of cases where we've had what sounds like a U2, and we've had needle tests eventually on them, and they've come back as Thigh 5. And we've also had quite a few U5s, and then we've put a needle biopsy in it, it's come back as a Thigh 2. So we don't mandate treatment of a U classification, but we will mandate treatment of a Thigh classification. And it's quite, if you look at the chart, in all the clinic rooms, there's usually a chart on the wall with the U classification on it. It's not as straightforward as you would think it is. There is a European different classification, which actually is a lot simpler, and it's something we should. They are looking at whether that is something that maybe we're more reasonable to adopt than the current new classification. But the U is embedded currently in our practice, and it's going to stay for a little while. And it's a useful adjunct. I think the benefit of the U is that if you get a U2, it will hopefully stop us doing too many fine needle aspirations. I think we were doing more needle biopsies when we didn't have the U2 as a sort of reassurance to say that we probably don't need to do them. So I think that's good. There is a lot of inter-observer variability on the U classification. One of the things when you're doing a U assessment is that it looks at the amount of vascularity within the nodule of the thyroid gland. and that really much depends on how high the button is turned up on the ultrasound machine for colour Doppler. So if the ultrasound is turned up very high, nearly all nodules will look like they're quite vascular. So you've got to have that setting done correctly, or you may upgrade or undergrade the nodule. So it's definitely not quite as good a science as cytology, but it is useful. And the next, obviously, is the thigh classification. And give us somebody else who I can see. Come on, I saw. Is anybody else in the room there, Erica?
Well, we have Katie and Liana.
Oh, Katie, come on, it's your turn now.
I'm not too sure. I think
Come on, give us
some
one.
kind
We know
of 3 means we would consider surgery, maybe depending on risk factors.
Don't start. You don't start at 3.
No, I'm not too sure about the other ones.
Just
I'm
1
saying
second,
we don't
guys.
do anything. We just monitor.
So yeah, sorry, I had to open the gate. Sorry. So you started at 3, Katie. Is that how you normally start counting?
No.
Come on, what is? Is that because the one you sort of knew?
Yeah, started the one I knew. The only one that I know for definite.
Okay, that's a fair point then. So so thigh 1 is inadequate, which means there's not enough cells, or there's only blood, or you weren't in the lesion, or it could be that it's a lesion that doesn't give up cells. So certain lesions like fat, lipomas, which you can get occasionally in the thyroid, and neural tumors will never give enough cells to be sure what you're dealing with. So thigh 1 we class as inadequate. It just means there's no cells in the sample. It also means you can't really take it any further forward. You're not sure. You can't rely on that. So you have to then make a clinical impression. Are you going to go back in and repeat, which is the commonest if it's a nodule that needs a needle? So you usually have to do a repeat needle test with the thigh 1. If you get more than one, so occasionally, if you've had 1 thigh 1, you're far more likely to get a second thigh 1. And so if you've got a second thigh 1, you then have to sit down with the patient and make a clinical decision of what you're going to do from there. And it is a bit of an uncertainty really what you do in that point, and it depends really on the size of the nodule, how suspicious you are, and how relaxing the patients are. Oh, what's that we got there? Somebody's put up a presentation. That's impressive. Is that the TNM?
Yeah, this was one of my presentations, just sharing the thigh system and the staging. How can we go through it? So within the age, Mr. Loughran, I think it's up now to 55, right? It was 45 before.
That's the big change in the new TNM8. I think the staging relies on the age of the patient, and it's been found obviously, and you probably read that in the paper I sent out, is that the age is quite crucial really as to how well these patients do. So under 55s do very well. The only slight caution with that, Haitham, is obviously if they are children, they don't do as well overall as the sort of middle-aged adults and young adults. So some of the children do have aggressive disease. But as an overall age cut off 55, I think is a good age to decide what stage the patients are. It doesn't change hugely how you treat the patients, but it is useful that, yeah. And you've got the thigh there. So thigh 2 is obviously benign, and that's pretty sensitive. That's about 95 to 98% correct. Has a very good positive predictive value. Thigh 3A, we know we divide that into thigh 3A and thigh 3F. I've always found the thigh 3A slightly tricky and uncertain what we do with that. As you know, we always repeat the thigh 3As, or we recommend we repeat them because of the potential to downgrade it to a thigh 2. You still have that dilemma. Once you've had a thigh 3, can you discharge a patient, or you still have to have some anxieties about them and keep them on observation? But theoretically, once you've had a thigh 2, if the nodule is not overtly growing or worrying, you could potentially discharge the patient. Thigh 4 is obviously suspicious of malignancy, and we've got rates between 60 and 75% for malignancy on thigh 4s. In our series, our cytologist looked at it, and it was below 60% on our series, and I think that's because there has been a downgrading of a lot of the things that were called follicular variant papillary carcinomas, and now a number of them are called NIFT-Ps. Does anybody know what NIFT-P stands for?
It's neoplasm with papillary-like nucleus features.
Yeah, it's a non-invasive follicular neoplasm with papillary-type features, yeah. And so these have been shown to behave in a very benign fashion. So it looks a little bit malignant on looking in the cells, but there's no invasion or out of the capsule. There's no vascular invasion, and there's none of the worrying or anxiety-producing features that will mean you're having potential for metastatic disease. And they followed a number of these patients up and realized that virtually none of them could get into any bother. It's a tiny percentage of patients with a NIFT-P who will have problems in the future. So I think we're pretty much happy now to call those more of a benign condition. The big dilemma is, what do you do with these patients? Do you follow them up? Are you happy to discharge them? And I think many clinicians, including me, would follow them up for a little while, especially if it was a decent sized nodule. But some do discharge, and I think that's not unreasonable. And then finally, you've got Thy5. But you can see Thy5 is not 100% positive predictive values, between 97 to 100% malignancy. And I've certainly had one Thy5 that came back as benign, and the patient had a total thyroidectomy, and it caused a lot of rumpus and complaints because he would have probably got away with a hemithyroidectomy if we had only a Thy4. But the Thy5 was reviewed externally, and they confirmed it was a Thy5. And so some of the Thy5s, very small percentage, are not going to be malignant, and you just have to keep that in the back of your mind. But overall, it's a very good sensitive test with a good positive predictive value, good sensitivity, good specificity, and certainly a lot better than ultrasound characteristics, which have some inherent weaknesses. So we've got a patient who's had a biopsy, and obviously these classifications don't really talk much about the type of cancer. Now, obviously, what the commonest type of cancer is papillary cancer, and it's overwhelmingly the most positive type. Second commonest are follicular, and then we are into the much rarer cancers, the medullary cancers. And the Thy classification is the same for all of those three cancers. It doesn't differentiate between the two. That gets us into a dilemma of how easy is it to make a diagnosis. And certainly some of the cancers, like follicular cancers, are very hard or impossible to diagnose on FNA. You'll always get a Thy3 FNA for a follicular carcinoma. The reason behind that is we're not looking at the morphology of the nucleus on these patients. We're looking at the presence of vascular or capsular invasion. So the cells in a follicular cancer look like benign, normal thyroid follicular cells. It's how they're behaving is the one how we diagnose it. So that's the problem with that. Medullary cancer can be diagnosed on an FNA, but a significant proportion of them, particularly in centres who don't have dedicated cytopathology, will give a Thy3F or Thy3 cytology. And it does require quite dedicated people that are interested in to make the diagnosis. And that's probably a real significant event for the patients, because with medullary cancer, as you're probably aware, the only treatment really that you can give is surgery. Radioactive iodine doesn't work. Chemotherapy, radiotherapy are not really effective, viable treatment options. There are some immunotherapy treatments, which we can talk about in the future a little bit later on. But these in themselves are really in a palliative setting or disease control setting, not a curative setting. So the only real definitive way to manage them curatively is surgery. And surgery involves a bare minimum of a total thyroidectomy, usually with central compartment neck dissection. And if you've had a Thy3F on an FNA, that patient is going to have a diagnostic hemithyroidectomy. And if they've had a diagnostic hemithyroidectomy and then you diagnose the medullary cancer, you're going to have to go back in and actually dissect the level 6 on the ipsilateral side. And if they've had scarring and operations on that side, then they are more prone and higher risk of having complications such as recurrent angial nerve injury and parathyroid damage. So if you can get a diagnosis for a medullary off an FNA, it makes a huge difference to the patient's journey. We'll come and talk a little bit more about medullary in a little while. So as I said, PTC is by far the commonest, follicular less so, and the medullary and the anaplastic is obviously far rarer, thankfully. Haytham's just put up a thing about micro PTC. So there are a number of, and I think this is where the paper is quite an interesting one, which we'll talk a bit about in a while, looking at the size of the papillary cancers. That does seem to be relevant. We stage the size of the PTCs on the TNM8. Can anybody just run past me what the T stages is for thyroid cancers at the current time? Anybody, any ideas? Come on, Haytham. I'm sorry, you put that slide up.
Yeah, I'm just looking at it. I was bringing the TNM classification from the ATA NCCN guidelines, and basically it's again T1, 2, 3, 4, where we are still measuring the size of the nodule. If it is less than 2, it's T1. 2 to 4, it's T2, but still intrathyroidal. T3, it's more than 4 with minimal extrathyroidal extension, I think, into the strap muscles only. And T4 is major extrathyroidal extension, I think, going to the esophagus, larynx, trachea, cartilage. Yeah.
So I think that's a quite useful way to look at it. And obviously the T1s can be diagnosed, differentiated into T1A and T1B, and T1A is up to 10 millimeters, including 10 millimeters, and T1B is 11 to 20 millimeters in size. And that is useful in how you predict whether a patient is going to require additional secondary management, or whether they would get away with a hemithyroidectomy. So T1A will be classified as a micro PTC, and it's one of the more common diagnoses we are making. There has been if you look at the charts for incidence of thyroid cancer, it looks like thyroid cancer is increasing enormously over the last 20, 30 years. Anybody, any reasons to think why that might be the case?
We are picking up early nodules by early investigation with ultrasound sensitivity, I think.
I think that's absolutely. So there's no difference in patients having more cancers than they did 30 years ago. It's just that, as you said, there's a lot more patients being investigated with ultrasound scan. And when anybody has an ultrasound scan, the radiographer, radiologist, or surgeon will often start at the thyroid gland, even if it's something else in the neck that is being looked at. And that's because it's quite good to orientate yourself on the thyroid gland when you're putting the probe on the neck, and it's quite an easy thing to pick up quite quickly. And so they'll sweep across the thyroid, and they'll often see nodules in it. And when you see a nodule, that can instigate assessments and needle biopsies, and you get down that pathway where it's hard to back out of, really. And so that's why we're diagnosing far more. And I think it's one of the reasons why it's good if a patient, I think we had a vogue where the GPs were doing a lot of direct access ultrasound requests for patients who had vague neck and throat symptoms. And I think it's probably better if they don't do that and they send them into us and we decide what needs to be done, rather than trying to upfront diagnose them with an ultrasound scan. Because I think you see this, the longer you've been around, the more you investigate patients, the more you are going to pick something up that may require intervention and that may not cause any problems with the patient. And this is when you read the paper. I think one of the key things of that paper is looking at the effects of microcarcinomas and the effect it has on the patient's lifespan, which basically has zero effect on when a patient was going to die. The chance of having metastatic disease that is going to affect their life or life expectancy is vanishingly small with a T1A papillary cancer. And I think when I started in Manchester nearly 20 years ago, well, it's 18 years ago now, all cancers, doesn't matter what stage, if you had a diagnosis, you would have minimum total thyroidectomy with radioactive iodine, There was a big vogue for doing central compartment neck dissections on the wall, going back in to do the contralateral and ipsilateral central compartments. And that was just how things were done in those days. And the morbidity was pretty high. There was a high incidence of needing calcium supplementation. There was certainly not an insignificant recurrent angial nerve injury. And there was a few papers that I read at the time. There was one, the Japanese papers, which is referenced in the paper I sent out to everybody. And they looked at conservative management of a T1A papillary cancer in a large cohort, over 1,000 patients. And it showed what the paper that you've read has gone through, which that these patients didn't get into trouble with thyroid cancer, and they had no surgical management at all, the vast majority of them. And the other area that also sort of highlighted to me that we are overtreating these patients was looking at some of the American studies. So from Memorial Sloan Kettering, where Nav was a fellow, they looked at their patients who had just a hemithyroidectomy for their T1s and T2 cancers. And again, there was a long follow-up up to 20 years. And the vast majority of these patients, over 99%, 98, 99%, didn't require further surgery or further problems. And they avoided the potential risks of hypercalcemia. They avoided the potential risk to the contralateral recurrent angial nerve and the effects of radioactive iodine. So radioactive iodine, although it's a relatively benign treatment compared to some, it still requires admission to hospital for 5 to 7 days where you are in an isolation room. That's difficult if you're a young woman with a young family. There are small, between 1 and 3% risks of secondary malignancies in later life, which is not insignificant when a lot of these are young and fit and well patients otherwise. And so if it's something that you can avoid, it would be good. And the other thing that also helped drive that was there was a big vogue in certain countries for doing quite radical surgery for T1As. So in some places, a T1A cancer would have a total thyroidectomy and bilateral, central and lateral neck dissections, which when we think about it now feels like a huge overkill. But a lot of the patients, so if they had a T1A cancer, about 50% of them were found to have positive microscopic nodal metastasis in level 6. They used very careful assessments, very narrow slices on all the lymph nodes and looked very carefully for it. And in the lateral neck, 40% had lateral neck disease, which was quite astounding when I first thought that. And I thought, well, are our patients any different here? Because it was mainly in the Far East, in Japan and Korea, that this was happening. And I thought, there's no difference between us in the West and those patients. And so all of our patients with T1A cancers must also have microscopic metastatic nodal disease. At presentation, by definition, 40 to 50% of them do. But we are not being so aggressive. And so all patients with these have the potential risks of these microscopic metastasis. But we know from the treatment with just a hemithyroidectomy or observation studies where we have no surgery, that very, very few of them, if any, of these metastatic nodal lesions cause any clinical problems in the longer term. And I think that was the combination of those three assessments helped us change our plan of how we manage things in Britain and in the Northwest. And so the MDT has become more and more conservative over the years, and I think that's a good thing, particularly for these low-risk patients who've got very low mitotic index. The chance of them rapidly getting out of hand is minimal. And so I think we are trying to change our policy of treatment to minimal treatment for low-risk patients. But then again, we've got to balance that with some of the patients do have high-risk, aggressive, invasive disease, even with the differentiated cancers. And those patients still, I think we possibly have undertreated some of those in the past and relied on partial surgery with radiotherapy as a backup treatment option with radioactive iodine. And I think those are patients we probably should be more aggressive with a surgical approach, where they've got invasive, difficult differentiated thyroid cancer. And that's something we also are trying to look at and change in the MDT currently. So that's a bit of a background of how things are progressing over the years, and I think we are certainly improving how we go ahead with managing these patients, and I think it will carry on evolving over time. Follicular cancers is the second commonest group. They are slightly more difficult because they are more prone to distant metastatic disease. And I think most follicular cancers, unless they are only minimally invasive, will usually have a completion thyroidectomy and radiation providing more often than not. They don't often get lateral neck or central neck metastasis. It tends to be, if they are going to spread, they will spread via vascular invasion, and then they can spread throughout the body. Typically, lungs and bone are two common areas where the follicular carcinomas will spread to. Medullary. I'm just watching there. There's various types of follicular carcinoma, which Nathan's going to pop me through that. I can see on his slides there. And some are a bit more aggressive than others. Some of the Hürtel cell variants that Nathan's mentioned there are a bit more aggressive, and they certainly require radiation iodine. So the next cancer that I want to talk a little bit about. Oh, has anybody any questions? I'm rattling on too much. Sorry.
Yeah, sure. A lot of questions, Mr. Loughran. So we have several questions starting from the investigations. So we know that we wouldn't FNA a nodule which is less than 1 centimeter. So whatever it is, even if it is a U4 or 5, we shouldn't FNA it if it is centimeter?
That's a really good question, Haitham. I think if you talk to most patients and you say they've got a 7 or 8 millimeter U5 nodule, and they ask, what's a U5 nodule mean? And you say, highly suspicious of cancer. It's quite difficult to persuade that patient that nothing needs to be done. It may be the right thing to do, and we possibly should try to do that. But a significant proportion of patients will not get that out of their mind and relax about it. And so I would think most patients with a 7, 8, 9 millimeter nodule, where you can typically tell it is U5, will end up having an FNA. It's certainly not that small a nodule to FNA. You can certainly get reasonable answers from it. But there is guidance that you shouldn't do that. But that guidance doesn't always work in the real world. When you've got a patient sitting there who is going to be, at the very minimum, they're going to have to come back and have regular scans. And as far as they're concerned, they've got a cancer in their body that we're ignoring. And so that can be a hard sell. And you have to take that into account. Sometimes you have to be pragmatic and agree to just get a diagnosis for the patient. And that diagnosis may end up being a hemithyroidectomy.
Yeah. So we know that the ultrasound and the FNA are operator dependent. So if you are still suspecting the findings which you have in your report, would you repeat the ultrasound for a small nodule, or just go forward with whatever the patient wishes, FNA or a hemithyroidectomy?
If you've got a patient who's comfortable to be monitored, then I would, and you can persuade them and they are pragmatic. And certainly some of the older patients are very much happy with that. If you talk to them quite in depth and tell them that it's a very slow growing disease that grows over years and decades, and they may theoretically only have 5 to 10 years left to live, some patients are quite comfortable to say, yeah, that's fine. If you've got a 20-year-old lady who's got a young family, it's going to be harder to say that just go and live your life, it's fine. And that patient will be at least very minimum offered a repeat ultrasound scan in 6 months.
I think that's the point discussed in the paper, which mentioned that the age is important in the aggressiveness of the tumor and the patient's concerns. So the old patients, I think they are not aggressively developing their tumors as the young or the middle age, right?
Yeah, I think it's difficult. I mean, the difficulty with the old age group is you've got the We know that if they're over 55, they can have more aggressive disease and be higher stage. But we know that there's a significant number of people who have post-mortem studies who have died because of old age or other conditions that have evidence of micro-PTCs on pathological examination. It's quite high, actually. It's a bit like prostate cancer in men. There's a high incidence of prostate cancer in men in post-mortem studies, and thyroid's very much like that. It's very similar in a number of head and neck areas. It's the same with if you've got a pleomorphic adenoma in a 75-year-old. Is there a 20-year risk of malignancy? Yes. Is the chance they're alive in 20 years? Well, possibly, but not a high chance of that. So you have to sort of balance all these, and these can be quite nuanced, patient-specific decision-making things that you do. Whatever happens, the more you operate, the more you realise that every time we operate on somebody, we, by the definition, do some damage to them. And the minimal damage that we do, the better. Biopsy is great. But some patients, things just go wrong and they have real problems. And that's easier to accept if they've got a really highly aggressive cancer than if they've got a very minimal worrying thing that is not going to kill them in the future. And then they've got to live their life with this long-term complication that's occurred. So it's much easier, I think, treating squamous cancer than it is papillary cancer in many ways. The squamous cancers, we know if we don't do something that's going to kill the patient. Papillary cancer, they may have lived with that until they died of something else completely differently.
Yeah. So the other question, please, Mr. Loughran, how many Thy3A could we have before offering an hemi? Only 2, or depending on the patient?
To be honest, you can have as many as you want. Oh, just 1 second. I've just got the dog's got to stay up there. 1 second. Sorry. Apologies, guys. Yeah, right. So yeah, on average, it is 2 Thy3As we would usually offer, especially in a young person with a biggish thyroid nodule. If the patient is super anxious about surgery and the nodule isn't growing, you could offer just monitoring of the nodule. But yeah, usually 2 is the average.
Yeah. And are we using this by any means in our MDTs like a prognostic risk factor whenever we do a total thyroidectomy? Like if there is any METS age, this was the MACIS risking for patients to know what is the prognosis. So is this by any means helpful? Like
it is helpful, but it's not something that we tend to usually discuss certainly in the MDT. It's useful to discuss with patients when you're talking about the risks and need for radioactive iodine. So I think the oncologists, it's quite useful for them to have some evidence or use of this to talk about whether it is worthwhile giving the additional treatments with radioactive iodine. And I think that's where we would tend to do it. What often happens in the MDT is that the MDT will give a couple of potential viable options, which can be put to the patient. And some patients don't like that, actually. Some patients just want to be told what's best to do, and they don't understand that sometimes in medicine, our science is not as good as we would like it to be, or not as precise or scientific as it seems. There's an element of art to some of the things we do, and they find that difficult, some patients in particular, to accept that and understand that. But usually you can have a sensible decision, and it's the same with all decision-making processes, and we see this in MDTs. MDTs can be driven by strong personalities who have certain thought processes about how things should be done. And if that person is the strongest personality in the MDT, he or she is potentially going to have more of a way of driving those decisions through. And the same can happen in a consultation with a patient. If you are, say you had a bad case last week, where you did such and such and it went badly, your chances of pushing that option to the patient will be lower the week after that than if he hadn't had a problem the week before. So it's not always as straightforward as we might think, and I think we use the various risk stratification and evidence as much as we can to help the patient. Most patients don't want to look and read huge involved scientific papers, but I think this is the one. I think the paper I sent out I felt was a really good summary of the state of play we are currently and the difficulties and areas of thyroid cancer treatment that we struggle with still, and why we have changed how we manage things over the years. And I think it's a really good one for all trainees to read and keep at hand. Certainly for examination purposes, it would be excellent, and as well as for your discussion with patients.
So yeah, going through the paper as this is related now. So
Yeah.
whenever we're getting a sub-centimeter 1 or 1.5, do we still have the option of discussing with the patient a HEMI versus the total? Is it down to the patient, or as long as we have a Thigh 5, we are going for a total
No.
into the BTA?
Yeah, so certainly with the Thigh 5, with an under 15 millimeter or not 15 millimeter or less nodule, you can certainly discuss with the patient about proceeding with just the diagnostic hemithyroidectomy, and it'd be potentially reasonable to ratify that with the MT first, and as long as the patient understands that there may be some adverse features that would make you more prone to going back in and giving a completion thyroidectomy. Can anybody think of anything why, after a 15 millimeter cancer, or say 10 millimeter cancer was excised, what features in the pathology may make us want to go back in? Come on, Haytham, you said plenty. Is anybody else there?
If there is any vascular invasion, if there is any
Is that
vascular,
Simon? Yep. Go on.
yeah,
So
I'm just in the clinic. I just finished the clinic. So
well
if there is
done,
any if there is a vascular invasion,
yeah. So vascular
or-
invasions is concerning,
or
because
any thyroid extension, yeah.
yeah. So yeah, you might find that's two of the things. So you might see this gross extrathyroid extension, which you weren't expecting on the ultrasound scan. You may have a number of foci vascular invasion, which will obviously make you anxious or concerned about disseminated metastatic disease potentially. Anything else that might be picked up on the pathology?
Mm.
Do you think of anything, Haytham?
I think, Mr. Loughran, I discussed that with you before. Some patients, whenever before surgery, you ask for the contralateral lobule ultrasound. If there is any contralateral nodules, even if it is U2, you will go for a total, I think, right?
Yeah. So you have some patients who have an ultrasound scan because of they've got a 4 centimeter U2 nodule in the left lobe, and the radiographer will tell, radiologist will say that looks benign U2. However, there is a 1.5 centimeter U5, Thigh 5 in the lobe that they weren't worried about. And I think in that scenario, the chance of that contralateral lobe causing problems by just being a big mass or growing is quite high. So a lot of those patients would actually be quite happy to have a total thyroidectomy because it's getting rid of the original problem that they came with. And so if you've got a big nodule in the contralateral lobe, I would certainly consider doing a total. The other thing, obviously, is if you're looking for multicentric or multifocal disease in the resected hemithyroid. So you might just have one nodule visible on ultrasound scan, but the pathologist may find 3 or 4 microscopic, 1, 2, 3 millimeter PTCs in addition to the one that you've taken out within that lobe, and that can push you to do more completion surgery because the incidence of micro PTC in the contralateral lobe is much higher than somebody who hasn't got that. Now, the dilemma with that is that micro PTC in the contralateral lobe, which is 1 or 2 millimeters, ever going to cause that patient problems? And it probably isn't, to be honest. So we do have a bit of a dichotomy of thoughts there, but the patients will always say, well, why, if I've got 2 or 3 small ones here which you didn't see, surely I might have 1 or 2 in the other one, and they're probably going to be right. And again, if you've got somebody who's young and otherwise well with a long life ahead of them, most of those patients will probably want the additional completion surgery at the minimum. If you've got somebody who has significant other comorbidities, that the anaesthetic risks are higher, you may not do that. And actually, that's another reason why you may do an upfront total thyroidectomy for a patient. So if you've got a patient who you really ideally don't want to give 2 anesthetics because they're not the fittest in the world, then sometimes it's more pragmatic just to do a total thyroidectomy of that patient, on the understanding that there is a risk of them needing a completion, and the downsides of doing a total in people who have a fairly high volume of thyroid surgery is not so high. The risk of needing calcium supplements is not enormous, and that may be the best way forward for that patient. So they're the main reasons why you may still decide to do a total in certain patients.
Just have a question for the points of the investigation. What's the time frame for repeating the ultrasound FNA? I mean, for the Thy3A, usually wait for 3 or 6 months, or
the recommendations were always 3 to 4 months historically. I think there is, if you do it too soon, there's an anxiety that when you do a needle biopsy, you can cause some scarring and some cellular change where the needle tract has been, and if you go back in the same site, you could be picking up those slightly abnormal cells from the recovery cells from the fine needle aspiration previously. So you want to ideally give it a little bit of chance to recover before you go back in if possible, and that was probably the rationale. It also gives you a bit of time to see if the nodule is changing in size, but to be honest, 3 to 4 months in a thyroid cancer nodule, the change in size is going to be minimal, if nothing, in most of them. So it doesn't exclude that, but it gives you a little extra element of comfort if you can get a Thy2 eventually.
And
I
is
find Thy3A one of the hardest things to do. It's one of the hardest uncertainties that we have, to be honest, in FNAs.
But for the Thy1, we just repeated because, or do you usually wait for Thy1?
Yeah, so to be fair, I mean, usually what I'll do, say if you're doing the one-stop clinic and you get, they look at the, in MRI, they will look at the sample, and then we'll say you haven't got enough cells. So we'll do an immediate repeat on that patient, ideally. The same in Salford, we get the same day result back in Salford. So come back at 4 o'clock for the result. If it's Thy1, then I'll do an immediate repeat as well.
Mm. Okay.
But timing is difficult, but I would say 3 to 4 months minimum.
3 to 4 months, yeah.
Mr. Loughran, on the paper, there has been a rule for the genomics in stratifying patients. Is this the future of investigation to know whether the NIFTP would be aggressive, like the BRAF, TERT? Are we into that point when we will be asking for genes?
Yeah, so we're not routinely doing that with our patients. I think genomic medicine is going to change a lot of how we diagnose and manage patients in the future, without a doubt. It won't be in my career particularly, but in you guys' eras, I think it will change things and how we do things quite significantly, really. I think it's used more in America. We still use it for, as a routine, we will use it for anaplastic cancers to see if they are going to be suitable for the immunotherapy medications. So for anaplastics, we will test the tumors for BRAF, but it's not a cheap or quick test to do for our routine patients, unfortunately, off FNA, to be honest. So it is something that I think will evolve over time, but at the minute we haven't quite got it for our standard cases as a routine.
Okay. Is there any difference in children with cancers, Mr. Loughran? Are you tending to do a total from the start, or still dealing with children as the same? Because in the paper, it sounds the same for adults and children.
Yeah, so historically, children have always had more treatment than adults, and the oncologists at the Children's Hospital have given most of the treatment, most of the children, total thyroidectomies and radioactive iodine, on the historic understanding that they can be more aggressive, and they can be more aggressive. I think one of the few patients I've had who's died of cancer, one was a 10-year-old boy, really, who he presented with hypoxia and blue lips and he had a chest X-ray which showed what they thought was miliary TB. He had some treatment for that, didn't respond quickly, so they did an open lung biopsy, and he had metastatic PTC in his lungs, and that was just widespread. And so he had a total thyroidectomy, and he had 2 courses of radioactive iodine, and his thyroglobulin dropped, I think, almost unrecordable. But the problem was it's completely scarred his lungs, and he had no viable lung tissue left. So he died of chronic lung disease within a year. And so they can be aggressive. But I think it's a discussion I'm trying to promote a bit more with our oncologists at RMCH to see whether we can consider just the hemithyroidectomy in certain instances. But they find it difficult to do that because it's not something they've done. Whereas they're very much, their MDC is very much like our adult one was when I started 15, 20 years ago. So it's a more tricky thing, but I think we need to start looking at that more for children to see if we can sort of consider hemithyroidectomy as an option for some of them.
Okay, but this is not the case for any child with a medullary, right? It will be a total for sure from the start.
Yeah, all medullaries, apart from somebody who's very frail, would have a total thyroidectomy at the minimum, yeah.
And are you involved in the multiple endocrine neoplasia patients who have like the adrenalectomy and thyroid? Do you do the thyroid with the same time they do the suprarenal glands, or do you wait for it?
In the children?
Or adults? Adults, I mean.
Oh, 1 second. Yeah, so the adults, the MENs are often diagnosed after they've had surgery. So you've got a young adult who's found to have a medullary cancer. They all get referred for genetics testing, and a percentage of them will have MEN. The majority still are sporadic, but there'll be a percentage of them, probably 20 to 30% of them will be MEN. And these patients will then be screened, obviously, with endocrinologists as well for VAOs. They usually have a scan of the adrenals as well as the chest and neck. And the endocrine surgeons will usually take them on if they've got pheochromocytomas. Prophylactically, we will do the MEN2A children when they're around 5 years of age, because we know that the chances of having a medullary cancer at that point are very low, less than 1%. They may have some C-cell hyperplasia, but it's unlikely that they'll have transformed into a medullary cancer. In the MEN2Bs, you're meant to be doing it around 1 year of age. However, I've never had a prophylactic MEN2B. I've got 3 children who have had MEN2B, and they were all diagnosed as new mutations. And none of them have had children. And they all presented with at the stage of metastatic neck disease.
So, Loughran, I have a question for the TSH level after the radioactive iodine and the follow-up during the clinics. So, what's the value that we are targeting actually?
It depends on. Yeah, it depends. So what tends to happen is the patients are risk stratified after they've had their radioactive iodine. So the oncologists will look at a patient, treat them. They will see what the post-operative scan shows, and they will also see what their thyroglobulin levels are. And if the thyroglobulin levels are unrecordable without antibodies, they will classify them into a low-risk group. Those patients will then be referred back to us, and the oncologists are very good. They will give us a TSH level that we are looking to try and maintain them at. A number of patients, however, are classified as high-risk patients, and they've usually got still a little bit of thyroglobulin or had quite extensive disease at presentation. And those patients, they often keep a hold of them, to be honest, and they will often try and keep their TSH lower. So they will often suppress those patients' TSH. When I started, all patients were giving quite aggressive TSH suppression, and we've gone away from that really. So most of them will between 0.5 and 2 will be a reasonable target range for TSH in most of the patients that we are following up, because they are low risk. I still think there's a role for not having TSH much higher than 2 on any patients who've had a thyroid cancer if we can help it. But you've got to balance that with the risks of being subclinical hyperthyroid for many, many years, which obviously has. But anybody know what risks there are from prolonged hyperthyroidism?
So is it TSH suppression means higher dose of levothyroxine, Mr. Loughran, or something
It
else?
does,
Because yeah, on the paper as well, the discussion about this suppression was, as you said, it's tending towards the intermediate and high risk and not the low risk patients because of the cardiac effect, osteoporosis in the older patients. So that's why we are not lowering the TSH levels as we have been before, right?
Yeah, so the key things you worry about are, as you said, osteoporosis and cardiac issues, cardiac arrhythmias, and atherosclerosis with a high dose of thyroxine. And once you've had a patient who's been on a reasonable high dose of thyroxine for a long time, with TSH suppression, it's pretty hard to get them down because they become absolutely adamant that they need to be on that set level. And they get used to being on a certain dose, and they become pretty miserable and depressed when you do try and drop them down. So it's best if you can get them onto a level where it's just comfortable, and the TSH is in a comfortable range in the lower half of the range, really.
Yeah. So when we are following up patients after thyroidectomy, I mean cancer, PTC, FTC, which investigations are we thinking of?
So it's a very straightforward assessment in the patients that come back. The lovely follow-up patients clinics normally, you will feel the patient's neck. The patients will need a thyroglobulin, and when you request a thyroglobulin level, you will get thyroglobulin antibodies assessed automatically, and you will also check the thyroid function tests. So you're looking for a patient who has got TFTs in the normal range with a low half of TSH in the low half of normal. You're looking for a thyroglobulin that's undetectable without thyroglobulin antibodies. If you've got thyroglobulin antibodies, you can't rely on that, and you have to therefore perform an ultrasound scan of the patients. Some of our patients, if they've had just a hemithyroidectomy, there's no point doing thyroglobulin. It's not really sensitive. It's not appropriate, and so those patients just require ultrasound scanning of the neck to check for any recurrent disease in the thyroid bed or contralateral disease or metastatic nodal disease. We'd still check the TFTs because a significant proportion of patients, the hemithyroid that remains will not manage, and they will need to have some thyroxine supplementation just to stop the TSH getting too high.
So if the thyroglobulin is, you said it should be undetectable, the thyroglobulin itself. So if it is just something low, I mean 3 or 4 or 5, it's still concerning.
That's still definitely a concern, because especially if the patient is TSH suppressed, and if they've got a recordable thyroglobulin of 1 or higher, there's a concern they may have recurrent disease.
Okay, and at that
low
point,
thyroglobulin, if they've got very high TSH, it's slightly, it still needs looking at, but it's slightly less of a concern because something is driving the thyroid cells in the body. But if they've got a TSH that's just in the range we want it to be in, and they've got any detectable thyroglobulin, that needs investigating. Yeah.
So, Mr. Loughran, if the thyroglobulin came back positive or high, and ultrasound of the neck showed something in the maybe a node, maybe a remnant, a residual. So, are we thinking of surgery or RAI, considering that the patient had RAI before?
The normal thought processes would be, first of all, what are the risks of leaving that patient and monitoring the thyroglobulin? And we know that's relatively low in certain instances, if the patient is accepting of it. Is going back in feasible with relatively low morbidity? And thirdly, is going back in going to normalize that thyroglobulin or cure the patient? And they are all three quite difficult answers, to be honest. For a fact, the third, where are we likely to fully cure that patient? I think the chances of you doing that are relatively small. If a patient's had recurrent disease after surgery and radioactive iodine, and they've got some visible disease left, there's a high chance that patient will always have some thyroid cancer in the body. It may not kill them, and something else may cause them to demise, but you making sure that you never get anything back in that patient is very unlikely, and you have to factor that in whenever you're making any thoughts about how you treat these patients. We do recurrent thyroid cancer treatments, and they would usually have repeat surgery and often repeat radioactive iodine. And as long as it can get through that and it's not too morbid, then it's not unreasonable as an option. But a lot of them still have some microscopic disease present.
Yeah, amazing. Any rule of radiotherapy in thyroids?
I think it's limited. We went through a phase again when I started 15 to 20 years ago of giving radiotherapy. From my recollection, and we did, I think Nav did have a look at this a few years ago, is that nearly every patient who has radiotherapy in this instance has significant late long-term radiotherapy effects. They nearly all have fixation of the larynx on one of both sides. The vast majority have significant swallowing issues. Some are peg dependent, and they all have really terribly scarred necks, more so than we see in some of the squamous cancer patients for some reason. But I'm trying to remember any patient who's got through this without quite significant morbidity. So there is a role for it, but I think it's limited, and it's decreased. It's been decreasing over the years. We've probably got it at about the right level now. We give very few patients unless they've got visible macroscopic disease left after surgery. And even that, and when that is the case, you have to think, did we do enough surgery for the first time, or should we consider even going back in and doing more surgery? So that is a dilemma. So I think radiotherapy is an option, but it's really not the ideal option at all. If it can be avoided in cases, it would be ideal if you can avoid it.
And the TKI's role is in these patients who failed surgery and radiotherapy? So when do we offer TKIs?
So the TKIs are offered to patients who have no viable surgical options or radioactive iodine options that are going to be curative, and they have evidence of increasing volumetric disease or thyroglobulin levels. So if you get, and we often look at doubling time of thyroglobulin, doubling time in size of deposits, and if they've got appreciable significant growth and rate in their disease process, then they will be suitable for the TKIs. Vandetanib's one, sorafenib's the other. These TKIs are not in themselves without risks and side effects. You know, there are cardiac risks. There is risks to the mucosal surfaces and on the hands and feet, and so they can be quite a tricky treatment to undertake with these patients, because often these patients are completely asymptomatic from their thyroid cancer recurrent disease. It's been picked up because of thyroglobulin assessments or scans, and they nearly always have no symptoms at all, really, secondary to what is visible. And so you might turn a patient who's got no symptoms at all, but just visible on scan or on thyroglobulin, into a patient who's had TKI and has significant side effects and problems with it. And there is a mortality with TKIs, although it's small, it is there. So I think we have to be cautious about TKIs. They have a place. They're not a panacea. They don't cure patients. They are there to control disease, but the disease is a relatively slow-growing disease in itself. And so the timing is crucial, and the oncologists, obviously, that's their job to look at this, and they're very important at deciding, along with the patient, when they should start these treatments.
Yeah, sure. Thank you. And in anaplastic patients, we are not offering surgery, as far as I understand, because it's quite a stage 4 from the start. Or should we do like a palliative surgery if needed?
There's no role in palliative surgery for these patients. We look back in the last 20 years or 25 years, we had one patient who survived with primary upfront surgery. He had a diagnostic hemithyroidectomy, and The fact that it came out, a number of us wonder if it actually was anaplastic, even though it looked like it was on histology, or it just was very lucky to get it so early. Most of them have got to a stage where they are irresectable and incurable. They present with stridor, it infiltrates all the surrounding structures. There was a patient of Nav's who was tested for BRAF mutation, was BRAF positive, underwent some initial TKI therapy, and it did significantly shrink, such that the patient could have surgery, because the surgery became feasible because it wasn't adherent to all the structures around. And that patient, I think, may even still be alive. I think that patient did quite well, but that's probably that one is the only genuine one I think we've had. So there's a role if it's BRAF positive and it's had a massive response to TKI therapy, but that is a tiny percentage of patients. Most of them are BRAF negative or don't respond to the TKI.
Thank you.
And the next question, when you've got those patients, is what do you do about their airway? And we looked at all of our anaplastic cancers in thyroid when Nav was a registrar, actually, and published that one. And in those instances, the conclusion was, if you can get an upfront diagnosis before the airway goes off, then the best way to do it is to try and avoid providing a surgical airway, if at all possible, and to try and palliate the patient as best as you can, rather than give them a tracheostomy. It didn't particularly prolong the life, and the life quality they had was very poor because it was often in hospital with issues with the tracheostomy. So we tried to go away from tracheostomies once we've got a diagnosis. It can be hard if a patient presents in extremis in the middle of the night and not to secure an airway when we don't know what the diagnosis is. The biggest dilemma with anaplastics is differentiating it from a lymphoma patient. And if you're uncertain and you've ever got a patient in that position, you will often give them some steroids anyway, and the lymphomas may respond to steroids where anaplastics don't.
Yeah, understood. Thank you. Amazing. Any other questions, guys?
Questions, because it's 5 o'clock.
Yeah. Any questions from the team?
No questions from this side.
Okay.
Thank you.
Well, enjoy your weekend, everybody.
Thank you, Mr. Loughran. Thank
Thank
you so much. See you in the
Pleasure.
next
All the
lecture.
best.
Thank
Bye
you
now.
so much.
Bye.
Bye-bye.